Welcome back to my YouTube channel Pharmalife. Please do like, share, subscribe. Peptic ulcer treatment we're going to discuss in this video. Hello friends, in the previous videos we have been discussed about peptic ulcer definition, etiology, signs and symptoms, pathophysiology, complications, diagnosis, etc. In this video we'll be discussing about the peptic ulcer treatment and we'll wind up this peptic ulcer topic. Treatment of chronic peptic ulcer. Treatment of peptic ulcer depends on the etiology of ulcer, whether it is HP or Helicobacter induced or NSAID induced, whether the ulcer is initial one or the recurrent one, whether the ulcer is present with complications like bleeding, perforation, or it is present without complication. All these things we have to consider for initiating the treatment. So our goals of therapy would be: first, relieve the ulcer pain, healing of the ulcer, prevent the ulcer reoccurrences and reduce the ulcer related complications. General approach to treatment. What are the general approaches we have to do for the treatment? If the patient is having Helicobacter induced ulcer positive, our aim of therapy is to eradicate that HP and prevent the ulcer reoccurrence and its complication. If it is NSAID induced, first we have to reduce the NSAID dose or we have to switch to COX-2 inhibitors. General approach to treatment includes: we have to take the drug regimens which contain the antibiotics like clarithromycin, metronidazole, amoxicillin, bismuth with anti-secretory drugs like proton pump inhibitors, H2 receptor blockers, etc. These are used to relieve the ulcer symptom, heal the ulcer and prevent the complications. Prophylactic co-therapy with proton pump inhibitors or misoprostol or switching to COX-2 inhibitors help us to risk the ulcer reoccurrence and prevent its complication. Coming to non-pharmacological therapy. Non-pharmacological therapy of the peptic ulcer include: firstly, we have to reduce the psychological stress, avoid the cigarette, use of COX-2 inhibitors. If it is necessary to use the NSAID to reduce the pain, we have to use COX-2 inhibitor instead of non-selective NSAIDs. There is no particular anti-ulcer diet. Foods to avoid include spicy food, caffeine, alcohol. These are the foods that cause dyspepsia. The food that cause dyspepsia exacerbate the ulcer symptoms, so we have to avoid this type of food. Vagectomy is done. It inhibits the gastric acid stimulations. Pharmacological therapy. Firstly, if the ulcer is due to HP eradication is our primary aim. So first we will do HP eradication by following the first line therapy. First line therapy includes proton pump based 3 drug regimen. It is to be followed for 7 days. Preferably if you follow 10 to 14 days, the results will be good. And if the first line therapy is not appropriate, we'll go for second course. Again we'll follow the PPI based 3 drug regimen, but this time we'll use different antibiotics. Or we'll go with 4 drug regimen with bismuth subsalicylate, metronidazole, tetracycline and proton pump inhibitors. Anti-ulcer drugs, histamine receptor blockers, proton pump inhibitors, sucralfate, these are used as alternative therapy. So triple therapy includes 2 antibiotic and 1 anti-secretory drug. And quadruple therapy include bismuth plus 2 antibiotics plus 1 anti-secretory drug. By using the triple therapy and quadruple therapy, we can increase the eradication rates and decrease the microbial resistance. um, how to what is the how will diagnose a peptic ulcer, what is the general course, we'll discuss in this flowchart. If the patient presents with ulcer like symptoms, like if the person is having only dyspepsia, only indigestion, and and he does not have any alarm symptoms, means we have to check whether he is on NSAID or not. If he is on NSAID, we should stop taking that NSAID, or we have to decrease the dose, or we have to switch to COX-2 inhibitors. Then we have to check. If symptoms resolve, means there is no need of further treatment. If the symptoms persist, means we have to initiate them. Histamine receptor antagonist or proton pump inhibitors like cimetidine, ranitidine, nizatidine or like pantoprazole esomeprazole, we have to initiate the therapy. If symptoms resolve means we have to continue with the therapy. If the symptoms persist means we have to do endoscopy to check the ulcer status. If the patient is not on NSAID, we have to check whether the person is having previously HP infection or not. If the answer is no, we have to perform the serology and check whether the test is positive or negative. If it's negative, we have to initiate the H2 receptor blockers and the flowchart continues. If it is positive means we have to treat with PPI based HP eradication, we have to treat it. So if the person is suffering with alarm symptoms like bleeding, weight loss, anorexia, we have to do endoscopy and check the status. If ulcer is present, we have to check for HP, H. pylori. If it is positive, we have to treat with proton pump inhibitor based HP eradication. Signs and symptoms after 1 to 2 weeks of post treatment. If it is no signs and symptoms appear, no, there is no need of further treatment. If signs and symptoms present and if he is on NSAID, then continue NSAID. If he is on NSAID or continuing NSAID, we have to first discontinue NSAID and treat with the histamine receptor blockers or proton pump inhibitors. If he is the HP status is negative and he is on NSAID, first we have to discontinue NSAIDs and treat with histamine receptor antagonist or proton pump inhibitors. If is continuing NSAID, if it is necessary to continue that NSAID, we have to treat with proton pump inhibitor followed by co-therapy with misoprostol, or we have to switch to COX-2 inhibitors. This is how we have to diagnose that whether it's HP induced or NSAID induced, what is the initial therapy we have to do. All this is depicted in this flowchart. As I already mentioned about triple therapy, proton pump inhibitor based 3-drug regimen. In this, first drug will be anti-secretory drug like proton pump inhibitors. So omeprazole 20 mg taken twice a day, lansoprazole 30 mg taken twice a day, pantoprazole, esomeprazole 40 mg, rabiprazole 20 mg. All these drugs, any one of the drug from proton pump inhibitor category we have to select, and the second drug would be clarithromycin. Clarithromycin we probably take 500 mg twice a day. And next, amoxicillin 1 gram BD. So firstly we'll start with 1 PPI clarithromycin amoxicillin. This is an initial therapy. If it is filled, we'll replace the amoxicillin with metronidazole. This is about triple therapy. We'll see about bismuth based 4-drug therapy. Same drugs and same PPI drugs with same dosage. Extra we are adding in this is bismuth subsalicylate of 525 mg 4 times daily. This is a quadruple based therapy. So we'll discuss about one by one drug. PPI, proton pump inhibitor. What is the mechanism of this proton pump inhibitor? It inhibits the basal and stimulated gastric acid. Usually proton pump inhibitors are dose dependent. PPI therapy is initiated. Acid suppression starts within 3 to 4 days of therapy as it inhibits the actively secreting proton pumps. Upon discontinuation, full restoration of acid takes 3 to 5 days. So proton pump inhibitors will work effectively when it is taken 15 to 30 minutes before meals. And to gain 24 hours pH control, the dose should be divided. The dose reduction is necessary in case of severe hepatic disease patients, as this increases the gastric pH. Bioavailability of ketoconazole diazepam, these drugs is altered. Omeprazole plus esomeprazole selectively inhibit the cytochrome P450 enzymes and decrease the elimination of phenytoin, diazepam, warfarin, etc. Long-term use of this PPI in HP positive patients results in atopic gastritis, bacterial overgrowth as the gastric acid secretion will be low, and the decrease in the vitamin B12 absorption. H2 receptor antagonist. H2 receptor antagonist drugs include cimetidine, famotidine, nizatidine, ranitidine. Mechanism of action is they will bind to the histamine type 2 receptor on the surface of gastric parietal cells and they interfere with gastric acid production and secretion. Cigarette smokers lead the long-term treatment with H2 blockers. Dose reduction is necessary in renal impairment as this H2 blockers elimination occurs through mainly renal route. And thrombocytopenia is the most common hematological side effect. Sucralfate is an anti-ulcer drug and it protects the ulcers. So it should be taken on empty stomach. 3% of the patients taking sucralfate will develop constipation. Interacting drug should be given 2 hours before sucralfate. Prostaglandins. Misoprostol is a synthetic prostaglandin. It inhibits the gastric acid secretion and increases the mucosal defense. So anti-secretory effects are usually dose dependent and the dosage range from 50 mcg to 200 mcg. 200 mcg 4 times per day is good for the duodenal and gastric ulcers. 30% of patients develop diarrhea as a complication. Misoprostol is contraindicated in pregnancy as it is uterotropic and produces uterine contractions. Bismuth preparation. Bismuth subsalicylate. Mechanism of action of bismuth subsalicylate is ulcer healing mechanism include an antibacterial effect, local gastroprotective effect and stimulation of prostaglandins. And it should be used cautiously in renal insufficiency patients, and the black color stool is because of the bismuth preparations. Antacids generally neutralize the gastric acids and it inactivates the pepsin. As I said in the etiology, pepsin is also one of the aggressive factor that causes the peptic ulcer. So antacids inactivates pepsin and neutralize the gastric acid. Aluminum containing antacids suppress the helicobacter and enhance the mucosal defense. Adverse effect with these antacids are usually dose dependent. Magnesium containing antacids cause diarrhea and aluminum containing antacids cause constipation. Interacting drugs should be given with a time gap of 2 hours. Next, what is the maintenance therapy or the drug regimen, oral drug regimen to heal the ulcers? As I said, commonly used is proton pump inhibitors. The dosage as mentioned in this table for the treating and the maintenance is usually of same dose. Like will commonly use proton pump inhibitors, H2 receptor blockers and proton pump inhibitors for to treat the ulcers of NSAID induced. As prophylactic therapy will use these drugs, and HP induced ulcers will use antibiotics along with these drugs. Non-compliance to medication or taking alcohol or cigarette smoke or having stress and avoiding medications, all this leads to the refractory ulcers. Refractory ulcers means the ulcers which reoccur after treating the ulcers. Refractory ulcers usually develops after 8 weeks of the initial therapy. So factors that contribute to unsuccessful eradication include that resistant organism presence, non-compliance of patient, low gastric pH, high bacterial growth, compliance of patient decreases with multiple medications, increased frequency of administration, increased length of treatment, adverse effects, costly drug regimen. All these factors contributes to the unsuccessful eradication of therapy and leads to the refractory ulcers, ante reoccurrence of ulcers again and again.